with us. We shall now go on to our next speaker, Dr. Sri Ganesh, who is the Chairman and Managing Director of Netradhama Group of Eye Hospital, and of course, a very amazing cataract refractive surgeon with a huge number of awards and accolades to his attribute. And he's going to tell us how would I handle a lenticule remnant in SMILE intra and post-operatively. On to you, Sri Ganesh. Sri Ganesh, you have to unmute yourself, maybe. Cannot hear you.
No, Sri Ganesh is not.
Can you hear me now?
Yeah. Yes.
Yeah. Okay. Good. Can you see me?
Yes.
Yeah.
Okay. Good. So let's start. At the outset, I would like to thank Chitra for inviting me to this excellent webinar on refractive surgery. And we have been doing SMILE for over 10 years now, and we have had some very interesting cases. I'll be talking to you about retained lenticule post-SMILE. So I am a consultant to Carl Zeiss Meditech. So for the first situation is where you have a retained lenticule intra. It is because of a lenticule tear. So this we will call as lenticule tear introp and a retained fragment. And this usually occurs when you have very thin lenticule, if you have low myopia, or you have OBL in the periphery, or if you have black spots typically in the periphery. And you can have some part of the lenticule which is retained back, and there is a risk of irregular astigmatism and loss of best corrected visual acuity if it's a fairly large chunk of the lenticule which you have left behind. So it is very important to identify for all beginners. We always ask them once they've removed the lenticule to put it on the surface of the cornea and check for the integrity of the lenticule, whether it is complete or incomplete. Examine the edges. You can also stain the lenticule with trypan blue and put it on a white sheet, and then it's clearer whether you have remove the complete lenticule. So when you're starting off, this is what you have to do. Suppose the lenticule is incomplete. It is not circular. You see that an edge is missing. Then you will have to identify the remnant in the pocket. This you can do by the use of a slit lamp in the Visimax. The Visimax itself has a slit lamp. So if you use the slit lamp, you can see where the peripheral lenticule is there. Because typically when you use the slit lamp, you see a very pristine edge if you remove the lenticule completely, but sometimes if the edge is not very clearly visible, that is where you have the retained peripheral bit of the lenticule because of the lenticule tear. You can also stain with tricot or predacetate drops. You insert it into the interface and then it will stain the edge of the retained lenticule, the tear which is there, and that's how you can identify it. The other option is to dilate the pupil and use a coaxial illumination, stereo coaxial illumination. So on retroillumination, you can see the edge of the lenticule. It appears a little darker. You can also use an endoilluminator from the side, put off the microscope light, use an endoilluminator from the side, and then you can identify the edge. Another technique is to insert an air bubble in the pocket. The air bubble itself will go and settle at the edge of the tear, and then you can identify where the tear is and where the retained lenticule is. So these are some of the techniques for identification. Let me just show you a video of a lenticule tear. You can see there is a lot of OBL in the periphery, and this was a lower myopia. This is an older video. So here the Chansey dissector is being used. The superficial plane is dissected, and then the deeper plane. And then the lenticule is extracted with the microforceps. Once the lenticule is extracted, then it is placed on the cornea, and on examination you can see that one part of the edge of the lenticule is missing. You can see that is where the arrow is, the white arrow. That is where. Now this is a small area, so even if you leave it, there may not be much of a problem, but it is ideal to explore and remove. So here we are using the slit lamp, and also you can see the air bubble there. So you go in and you can see that is the area where the edge, the lenticule side cut is not very clear. You can go and then dissect it, remove it with the microforceps, and you can see that is the area. You can even match it to the lenticule like a jigsaw puzzle and see that it matches correctly, and then you know you have removed the lenticule. So that is the intra-op management of a lenticule tear or a retained lenticule. Now let us, okay, coming to prevention and management. So it's very important. Prevention is better than cure. So you will have to see that you completely separate the lenticule from both surfaces and the side cut along the entire circumference before you try to extract the lenticule with your microforceps. And in low myopia, again, the risk of this happening is more. So you can increase the peripheral thickness of the lenticule to 24 or 30, 25 to 30 microns. And if you have a thicker peripheral part of the lenticule, then the incidence of these lenticule tears is less. Also, if you have OBL in the periphery, you have to be very careful when you are dissecting and see that you completely dissect the lenticule. Like I showed in the last case, because of the OBL and the low myopia, there was a tear. Coming to the retained lenticule post-op. So the patient may present post-op with loss of best-corrected vision and blurring of vision. There are two options. One is to explore through the previous smile incision, you explore the pocket and you can attempt to remove this. And the second option is to create a flap using the circle software, lift the flap, and then you do an open exploration and then remove the remnant which is there. So first we will look at exploring through the same pocket. You can open up the previous smile incision very easily, and typically you wait until the cornea clears. Suppose you have not been able to remove the lenticule completely, then and you have spent quite some time dissecting, then what happens is there is some amount of corneal edema and the visibility reduces. So typically the cornea takes about a week or 10 days for it to completely clear, and that's when you can do a proper assessment and go in and explore. You should always ask for the surgery. If you have done the case, then you review the surgical video. The case has been referred to you, always ask for a surgical video and see that there is a completeness of all the stages of the lenticule creation by the laser. That is the refractive cut, the side cut, the cap cut, and the incision. So if there is some incomplete treatment of the laser, or if there are black spots, then it may be more difficult. You may not be able to do a closed exploration. So always look at whether the laser was complete and whether the laser treatment has been done properly. And if that is there, then you can go ahead with the exploration in the pocket. ASOCT has to be done. You do a topography. Topography may show irregularity. ASOCT will definitely give you clues about the location of the retained lenticule remnant. Sometimes you may not be able to even make out of the ASOCT, so it is a good idea to always dilate the pupil and do a thorough examination with a slit lamp, a retroillumination examination, and then on retroillumination sometimes you can see the edge of the lenticule. So I'll show you some cases. So this was
running late already.
Okay, just the cases. Give me another 3 minutes. This is post-smile right eye, uncorrected vision. He had 20/40, was referred. Best corrected vision was -1 +2, improving only to 20/40, and procedure was abandoned because they were not able to remove the lenticule. And this, you can see that the topography is very irregular. And if you look at the OCT, you can see that there is a retained lenticule there. This is exploration. You go in through the same pocket, and then you can see, you can look at the lenticule remnant there, and then you can dissect both the deep and the superficial surface. And then this was a patient where the surgeon said that he was not able to remove the lenticule at all. It had crumpled and then gone deep in the pocket. So you can see that the entire lenticule is there. And this is the pre-op and post-op topography. You can see that topography normalized very well, and this patient had a 6/6 uncorrected vision. This is a final uncorrected vision. Best corrected improving to 6/5. This is the pre-op OCT and the post-op OCT showing removal of the lenticule. Open exploration can be done with the circle software like Dr. Sheetal showed. Indications are irregular topography, ASOCT is inconclusive, and it may show if ASOC shows multiple planes of entry. This is a case, I'll just show you. This is a 33-year-old female, spinal procedure, left eye was complicated. Best corrected vision, there was a loss of best corrected vision, improving only to 20/40. And this is the primary video. You can see there's a lot of black spots here. And there's a large patch here. Okay. And this is when, suppose you have a large patch and if it's in the center, then it's best not to proceed with the dissection of the lenticule. Here, we are proceeding with the dissection of the lenticule because the black spot was in the periphery. You can see that there's more resistance when you're dissecting the deeper plane. The lenticule is removed. It is found to be intact. There is no remnant as such which you can notice. In all difficult dissections, you have to examine the lenticule. But you can see the topography shows central steepening and there is irregularity. ASOCT was not remarkable. You can see it's fairly okay, but epithelial maps were irregular. And on retroillumination, you can see that there was some shadow here, which showed that, okay, there may be some remnant. So here we are doing the exploration through a circle software and we just lift the flap. And here you can see that there is a sliver of tissue. It's a very thin sliver, maybe about 10 or 15 microns. So you can dissect that sliver off. That was what was giving rise to the central steepening on topography. And you can't see it on OCT also because it's very thin. It's just a thin sliver. So we removed it and just did a 20 micron PTK just to smoothen the surface. You can see that's the remnant, very thin. That's the PTK being done, and we put back the flap. I'll just show you the post-op. You can see this is the post-op. She improved to 6 parts, and this is the pre-op and post-op topography. You can see the topography has normalized. This is a clinical photograph post-op. You can see that there are no shadows. The retroillumination is very clear. We have published quite a few cases of the retained lenticule and management in the JRS. So if you are interested, you can read this article. Thank you very much for your attention.
Thanks a lot, Sri Ganesh. There's a whole lot of learning from your talk, but it's running so late that I'm not able to use your experience longer. And I'll sure come back with another different webinar later to learn some more. Thanks a lot.
I just want to ask you one thing. Intra-op, you can also use an intraopacity microscope too.
Yes. You can use it, but you have to shift the patient to the
another
OCT. But it is better, of course. Intra-op, sometimes it's inconclusive, the intra-op OCT. So staining probably is a better idea.
Yes. Tricot staining definitely helps.